Alright, so good evening everyone and welcome to this public lecture. Thank you all for signing up and for coming here. My name is Genevie Fernandes and I think most people in this room know me, but for those who don't know me, I am a final year PhD student at the University of Edinburgh and I work here with the Global Health Governance Program at the university, and we have organized this fantastic exhibition here in Global Health. And I work with Professor Devi Sridhar on a larger research project on the World Bank and its role in global health and maternal and child health. And before coming here to Edinburgh, I worked in India as a researcher on maternal and child health projects, and that's where I'll be drawing from some of my experiences from back home and from the broader literature as well. Can I have a raise of hands? How many people have worked in maternal and child health in any form or fashion? As a researcher, policy person, or... Alright, fantastic. So for the benefit of the group, I will just maybe go through a couple of concepts, that I will be using very often so that we're all... April, you didn't raise your hands. You're a medical student.
So technically it's not working.
It's not working, all right. Okay. So, the talk is about declining maternal and child mortality rates in the world, and the idea is to kind of look at where we are right now on this topic, and then also learn from some lessons from the past, in particular from England, from France, and then sort of trying to wrap up on a more positive note with a case study from India. So, maternal mortality and maternal mortality ratio. So, maternal mortality refers to a maternal death of a woman due to reasons related to childbirth, and the death that happens within 42 days of termination of pregnancy. That is considered as a maternal death. And maternal mortality ratio, or MMR, is essentially the number of maternal deaths for every 100,000 live births. Now, the next sort of area is infant and child mortality. Infant mortality is the death of a child within the first year of birth, whereas child mortality is the death of a child within under 5 years of age. And again, you can see the sort of ratio. So for maternal mortality is deaths for every 100,000 live births, whereas for child and infant mortality is the deaths for 1,000 live births. Just to bear in mind when we discuss about these falling rates. So when we talk about declining maternal and child mortality rates, these are the numbers that we are referring to. Alright, so I'm going to play a small clip. It's about 2.5, maybe 3 minutes long, just to give us a sort of context for this topic.
तीसरे व्यक्ति मेरी जब यहाँ पे कोई गाड़ी का साधन नहीं था, मेरे सास नहीं थी, बहुत ज्यादा गलत हुआ। ठेला पर यहाँ से फिर ले गया, रास्ते में मेरे बेटी का जन्म हो गया। झाड़ फूटा जो पूरे होता है ठंडा महीना ये हो सकता है। हम ही नहीं चाहते कि मेरा जैसा दुख किसी का हो। मुसौरा में ज्यादातर गरीब लोग हैं। पहले टीवी से लोग मरते थे, चेचक से मरते थे, कालाजार से मरते थे, डायरिया से। हर मंथ में 2-4 बच्चा एडिट करता था। आज जब से आशा है बदलाव, बहुत बदलाव हुआ है। साड़ी हम लोग को मिला है तो ये ऐसे ही साड़ी पहनते हैं जो नीले है और नीले पागल है। पैसे के लिए नहीं तो मैं हम काम ऐसा करेंगे ना किसी को भला हो। रोज सुबह हम गिरवेट के लिए जाते हैं, चल के करते हैं। हमको इतना लोग जा रहे हैं, हमारे हम किसी को बता रहे हैं तो उसको फायदा हो रहा है तब ना मेरे पास आ रहा है। हम लोग काम करना स्टार्ट किए तो माता मृत्यु भी कम हो गया, बच्चा के तो बहुत कम हो गया लोगों का। बिहार में अच्छे हो गए।
Alright, does this make us feel a little hopeful? So, what are the key things that we kind of picked up from this video? Anything that you picked up that sort of struck you?
The value of healthcare.
The value of healthcare, exactly.
Saves lives.
Mm-hmm. Any other things that struck you?
Things that I've taken for granted so far.
Mm-hmm.
Expert healthcare is something that was always available.
Mm-hmm. Mm-hmm.
And this lady, I mean, clearly these people have to travel for hours and
Mm-hmm.
probably even then it doesn't reach them on time.
Mm-hmm. Yeah, there are communities that have to travel a long distance to get to basic healthcare. Alright, so just to kind of take some key ideas from this video is, generally there's this sort of positive sense that we're getting that things are changing. I mean, we saw this lady who is a frontline health worker, and in many developing countries where my experience comes from, the frontline health workers sort of are the foot soldiers of the health system. They work a lot. They do a lot of. They work on multiple issues, and in most cases they work on a voluntary basis, and they are rewarded. Of course, they are given certain incentives. Which are linked to certain tasks. For instance, now this frontline health worker will probably get an incentive for taking women for institutional delivery, so where she can have safer and healthier delivery. So this lady says that maternal mortality has come down, child mortality has come down, and obviously we see an ambulance in the picture, which may seem ordinary maybe for some of us, but it's a huge, it's a big reason why more women, more children have now access to health facilities. And then you also saw a specialist in the hospital who saw the lady. So again, well-staffed sort of health facilities, that's another reason why sort of maternal mortality and child mortality has come down. So just to kind of, I'm going to use this. Alright, so just to give you a sense of like the global picture, I'm taking data from 1990 to 2015, and as you can see, this is the maternal mortality ratio that we, for those who joined in a little later, Maternal mortality ratio is essentially the number of maternal deaths for every 100,000 live births. So we can see that it's come from 385 to 2016. It's almost halved in a span of 25 years. This is a global sort of estimate. Then we look at child mortality, and even child mortality and infant mortality has dropped down. So these are the changes that Manju, the frontline health worker who we saw in the video, these are the changes that we are seeing around the world. Why are women dying? Why are women dying during childbirth? So hemorrhage contributes to at least 18%. So a lot of women die during the childbirth. So a lot of deaths happen, they're preventable. They're preventable if women receive timely obstetric care. And we can also see indirect causes. Any idea what indirect causes could be? So we have causes like hemorrhage, we have HIV/AIDS, we have obstructed labor, sepsis, maternal infections, complications of abortion. Now, complications of abortion, it is because, again, there is lack of access to safe abortion services, safe medical termination services. Even though they are absolutely legal and available in countries, there is still, in some countries, a lot of social stigma that is attached to accessing the services. So, for all the medical students in the room, what are the other indirect causes? Any guesses? I can give you a clue. Infectious diseases other than HIV/AIDS. So malaria. Malaria has a huge burden, so a lot of pregnant women are at a high risk for that infection. Then you have these new infections like Zika, you have Ebola, and then you also have anemia. So we were running a session today afternoon with school kids aged 14 and 15, and we had a very good discussion about anemia. So how many of you have heard about anemia? Fantastic. So anemia is iron deficiency anemia is one of the most common forms of anemia. And in countries like India, for instance, about 50% of pregnant women, 60% of adolescent children, especially girl children, suffer from anemia. And it has like long lasting impacts on their health, because if you have a young adolescent girl who has anemia, who has iron deficiency, she's at higher risk when she gets married. And if she gets married at a young age and has children, too many children, too quickly, so if you see that whole cycle, she's at higher risk for problems like hemorrhage, hypertension. So you see these nutritional causes and social causes kind of give way to the biological sort of causes of maternal death. So it's all kind of interconnected. And again, we look at the causes of neonatal and infant death. So neonatal is essentially the first month of the child's life, whereas infant is the first year. Infancy is the first year of the child's life. And we can see pneumonia. Pneumonia takes a big chunk. Pneumonia is one of the biggest killers of children, and it's absolutely preventable. So apart from pneumonia, we also have diarrhea. And again, in places where there are problems with access to clean water, to sanitation, the risk for catching these infections increases. So when we look at health solutions, it's not just about medical and technical solutions, it's also looking at other sectors like providing clean water, providing clean sanitation for the communities. So I just wanted to put this slide here just to give you a sense of how to improve health. So when we think about a health problem, right, the instant sort of idea is health service, right? Health service, what is the treatment? What is the treatment for this? But, so you have suppliers, you have the supply side, you have the providers. But you also have behaviors. You also have healthy behaviors. So for instance, if a mother breastfeeds her child, that's a healthy behavior, right? She doesn't have to go to some place to do it. If she has the right kind of information, she can do it in her own house. But the mother needs the information, she needs the support, and there could be several misconceptions related to breastfeeding. So when we think of a health problem, this is a good frame to keep in mind. You have the demand side and you have the supply side. And when I say demand, the government, for instance, country's government may offer incentives, may offer women money to come to the hospital and give birth. But there are so many factors that can influence the woman's behavior, or can lead to behavior change to actually go to the hospital. It's not just the distance. It could also be support. I mean, probably the husband makes the decisions, or the older woman in the house makes the decisions. So I won't go through all of these in detail, but just to give you a sense that over the years, of course, there's been a lot of evidence-based interventions that various countries, developed and developing countries, have been implementing to improve, to bring down those maternal and child mortality rates. This seems very complex, but this is something I've kind of put together over years, by, not over years, of course, but just based on my work and based on the evidence. So you can see the top blue line over there, right? So this is kind of the life cycle approach, where we don't just look at the mother or the child in isolation. You look at the whole cycle. And the idea is that if you approach the whole cycle, there are sort of benefits for the next stage. So right at adolescence, you work with young girls, young boys who are anemic or have health issues, or you work with adolescent girls on menstrual hygiene and awareness about reproductive health. So these are very simple interventions, and I can discuss these in detail if you like after the lecture. But these are very simple interventions, cost-effective interventions that have been used by countries over the last few decades to bring down their maternal and child mortality rates. Something as simple as consumption of IFA tablets, which is iron folic acid tablets. So if you suffer from anemia, the government healthcare facilities will give you iron tablets, which you can consume along with a good healthy diet. Then, but do you know what is the most impactful intervention here to reduce, for example, maternal deaths? So it's obstetric care, right? So you need improved obstetric care services. You need blood transfusion centers in certain places when the risk arises. All right. So this is the map of the world, obviously, but why does it look so distorted?
Burden of maternal mortality?
Yes, it's a good student. So now I showed you the global rates, right? Globally, we think the figures, the numbers are coming down. But if you look at this image, you can obviously see North America and South America have gone to size 0, and we have like Africa, we have Asia, and we have the Middle East. They've bulged out of proportion. So this map essentially illustrates the burden of maternal mortality. So while globally the numbers have come down, and it's great, it's a great sign, but in several countries, the numbers, while they have come down, because of the population of those countries, the numbers are still high, and a lot of work still needs to be done. For instance, India and Nigeria contribute to about 50% of all maternal deaths in the world, and it's around the same figure for child deaths as well. So, but again, you have to also consider the population of these two countries. So it's not to say that these countries aren't doing anything, but with the sheer population, the numbers also increase. Again, this is child mortality, and you kind of see the similar picture. Now, we've gone from global to like inter-country, right? So now let's go to one country. So what I've done here is, I've taken some of the major states in India, and in the next column, I put the maternal mortality ratios. So you'll obviously see, you'll see in the table, there's a huge variation between some states. So you'll see the state of Assam, which is on the northeast part of the country. It has a very high maternal mortality ratio, whereas southern Indian state like Kerala has a drastically low maternal, it's not it can still go down to 0, but comparatively it's quite low. Just to give you a sense that when we talk about health, we need to look at disaggregated data. We need to look at the global data, but we also need to look at data from different provinces. We need to look at data that is disaggregated by gender. Because for instance, if you pull apart child mortality data by male and female children, you will find that in certain provinces, female mortality is much higher than male mortality. So then as a policy person, as a planner, as a researcher, you may then want to have targeted interventions for female children and try to understand why female mortality rates are higher than male mortality rates. Alright, so now that we're done with the global sort of picture, I thought it'd be interesting to kind of go back to history and look at lessons that have been learned, because if you look at Northwestern Europe, actually, if you look at this graph, it pretty much tells you a picture. So this captures maternal mortality from 1925 to 1950. And you can see you have E and W, which is England and Wales, your USA, Netherlands, Sweden, Australia. So now look at the starting point, 200, 400, 600. Now these are the figures that we're still seeing today in many countries in Africa and South Asia. So, and this was like 100 years ago, right? So developed countries were at the same point in maternal and child mortality where many developing countries are right now at the moment. So what did they do? What did they do differently to bring down? Because obviously you can see a drastic decline from around 1934, 35, right? So something must have happened across Europe. So let's find out. Alright, so I've tried to pick them apart by countries. So I'm looking at England and Wales because from the literature, this is the data I found. I didn't want to complicate it. Now you can see that we have data starting from 1880, and there is a drop after 1890, and there's an even bigger drop around the 1940s. So obviously two big things happened at these 2 points. Any of the medical students, would you like to guess? Is this taught in your syllabus?
No.
Okay, that's good.
NHS has started?
Okay, what did he say? NHS. So when did the NHS start?
49?
1948, close. So the NHS, for everyone in the room, is the National Health Service of the UK, and it was built on the principle of universal health coverage for all. So that started in 1948. So you can obviously see a decline from that point. But before that, we see massive declines, right? So 1880, we have Listerian antisepsis. Anyone would like to take a guess? Is this the name of a chocolate or cake? No. So back then, maternal mortality was very, very common in England and Wales, and like in many other countries, and it was very common for a woman to die in childbirth, and many of these deaths happened in hospitals, right? So it happened obviously because of unhygienic conditions, certain practices that were not evidence-based. So then in 1880, we had the discovery and the introduction of this antiseptic sort of element where doctors had to, for example, they had to go and wash their hands before performing a surgery, but they had to use proper hygiene. So these things, which are so commonsensical to us, were not practiced in that time. So something as simple as that, but obviously it took some time to kind of pick up, right? Then you had training of midwives. So midwives were trained to identify high risks. They were trained, and in some places in England and Wales, they were supervised by the local doctor to perform high-risk deliveries, because even back then, most of the deliveries still happened at home. So while we had antisepsis and all these practices introduced in the hospital, not many women were coming to the hospital, deliveries still happened at home. So training midwives really helped to drop the maternal mortality rates. These are medical terms, but just to give you a sense, it helps to control infections, it reduces deaths due to all sorts of infections, and obviously obstetric care started getting more advanced from the 1930s onwards, and that was across Europe. That was also observed in the US. So you had cesarean sections for high-risk pregnancies. And then finally, as Adrian said, NHS was introduced, which meant that a lot of people had increased access to healthcare in the US. So we have similar sort of, obviously from the US we get data only from the 1910, 1920 onwards, but we have similar reasons here. Training of midwives was, by the literature, considered as a big factor for drastically reducing maternal deaths in the US, but this was a very tough struggle. There was a huge struggle between the midwives and between the clinical practitioners. So that is why sort of policies for midwifery and nursing associations took time because of the political struggle. Again, similar pattern. So we see that in the 1930s, public medicine sort of really was responsible for bringing down maternal deaths. All right. So now, child mortality. It's a beautiful painting, right? So what's going on here in this painting? Who wants to take a guess?
Vaccines? Are being administered?
Where can you see vaccines?
I don't know, I just guess. That looks like a doctor
Yes,
with like
good.
a vaccine card and there's a mother and her child.
Yes, okay, good.
Is it something around breastfeeding?
Good guess. Breastfeeding? Any other guesses? Alright, it's pretty simple, right? There are mothers and there are babies, and that man looks like a doctor. Hopefully, he is a doctor. So, well, it's a painting, so we don't know. But just to give you a sense of the concept. So, in England and in France, in 1880s, obviously we had the Industrial Revolution. So there was a lot of industrialization, there was a lot of urbanization. There was a lot of crowding in cities, right? And sanitary conditions were not that great. But when everybody went to work, it also meant that women couldn't breastfeed their children. Many working women couldn't breastfeed their children. So we have this concept of milk depots that started emerging, and this concept actually was sort of introduced in France, and it's called, Felix, correct me if I'm wrong, goutte de lait, which is drop of milk. In France, there were these two sort of very interesting initiatives that were set up from 1890s onwards. The first initiative was called Consultation de Nourrisson, which means basically consulting, giving healthcare for young children. So, so the basic concept was that wherever there was this first organization in a hospital, mothers were encouraged to keep coming for regular checkups and for a month. And the doctors would monitor their babies, monitor their weight, monitor if they had any risk of infections, and they would promote breastfeeding. Very simple, very basic sort of interventions that we see today as well, right? But at that time, it was very pioneering because it wasn't done then. And so that was the first bit, so the monitoring of the children. And the second bit, that is goutte de lait, milk depots, it was mainly targeted for women who weren't able to, breastfeed their children because they were either working or they had certain problems. So this concept picked up in England and in Wales, post 1900s. And these initiatives really helped to bring down the infant mortality rates in both these countries, and they were picked up in other European countries as well. And so apart from breastfeeding, milk depots, there was another thing that happened that drastically brought down child mortality rates, which was improvement in sanitary conditions, improvement in clean water supply and sanitary conditions. That just brought down rates of mortality due to cholera, due to diarrhea. Alright, So just to sum it up, we have like what lessons have we learned from developed countries that 100 years ago had mortality rates as high as certain developing countries today, right? So obviously the discovery and sort of the introduction of public medicine, then we have advances in obstetrics, we have training and supervision not just of clinical providers, not just of doctors, but we also have a lot of nursing staff, a lot of frontline health workers being trained, a lot of midwives being trained, and then finally promotion of healthy behaviors such as breastfeeding. And politically, the one major thing that I pulled out was access to healthcare. So across Europe, you have initiatives like NHS. In Scandinavia, you have access to free healthcare. So that was a huge factor there. So just to kind of introduce this concept of a health system, I'm sure most of us have heard or sort of understand, what is a health system? A health system is basically sort of like an organization that you need to implement good health in a country. So these are the 6 basic components of a health system. You have service delivery, you have the workforce, right? So we had the midwives, we have the nursing staff, the doctors, you have the information, you have the public medicine, you have medicines, vaccines, and technologies. You need the financing to finance all of this. And then finally, you need leadership and governance in order to ensure that things are implemented as planned, bottlenecks are checked, they're addressed. So we know these lessons, right? We are also implementing them. We know that these are where we need to put our efforts in. So what's really stopping certain countries? What are the issues that are stopping certain countries from actually implementing good healthcare for women and children? Just very basically for us to think about it, right? So you have political factors. So it depends on which political party is in power. What is their mandate? Whether they want to invest in health, or they want to invest in defense, or they want to invest in technology. So that's a huge factor at the country level. Then obviously economic. I mean, do we have the funds? Do we have the expertise to reallocate funds from defense to health? Right? So you start with political will, then you need to have the kind of expertise. Like in many developing countries, we were just having a chat with colleagues before this talk about how in so many developing countries the money is there, right? Because for example in India, the richest man in India is probably worth 43 billion US dollars, right? So the inequalities are so wide. So in countries like that, just by improving tax collection systems, you can increase revenue that can be freed up for investment in health and other social sectors. Then you have social and cultural barriers, behavioral barriers. So not just providing health services isn't enough. How do you convince women, men, children to actually access health services, to actually adopt healthy behaviors? For example, breastfeeding. We know it's great, we know it's life-saving, we know it doesn't cost anything, right? But when I was working on a project in Andhra Pradesh, a state in eastern part of India, it was a very common belief that the first breast milk, which is colostrum, it's a yellow, sticky milk, right? It's discarded in some communities because there is a misconception that it's going to be very difficult for the children to digest. Whereas that colostrum is so important and life-saving for kids because kids don't have a strong digestive system, but that builds their immunity. So simple things like that, like any place, if you're looking at a health topic, it's very important to understand what are the sort of social, cultural factors that can impede practice and behaviors, and this can vary from like one locality to another, Then you have behaviors, you have biological also. I mean, there are certain genetic dispositions that certain communities may have. All right. So I'll try and end my talk on a positive case, and for those who are here in the morning, it's a repetition of the case that I discussed with a bunch of students, so apologies for that. But this is a case from India, and it's a program on reducing anemia. So we've all heard of anemia, right? It's iron deficiency, and so Haryana, the state where this project that I'm going to talk about, is from North India. You can see that red bit over there. So, and I've also put a picture that I clicked from Haryana when I was working there. This is the state in a snapshot. It's fertile. It's very rich because of its revenues from agriculture. You can also see a lot of modern agriculture taking place. So, in terms of an economic profile, the state is one of the richest states in the country. But in terms of its maternal and child health profile, it's quite wobbly. I mean, 50% of the pregnant women there suffer from anemia, a high amount of maternal deaths, and so I was part of this one project. We were working here in 2015, and we did a brainstorming to just discuss that. Okay, we're giving all health services. The health staff are motivated, but it's not happening. Why are women not coming to the health center? And after a lot of discussions, of course, with a lot of senior people who've been there in the field, and a lot of a few anthropologists and a few social science people, they're like, guys, you're missing the elephant in the room. The gender norms are so obstinate in Haryana. So women are treated they're treated as second-class sort of citizens there, and it's very, very hard to get anyone's attention to do something for women. Like, I'll just give you a simple example, and this may be common in some other places as well, but in Haryana, the boys will get served food first, and whatever is left will then be had by the girls. If the boy is sick, the boy will be taken to the hospital, So if a family is deciding on, where do I invest my resources to take a taxi and lose my day's wage, I'll get my boy to the hospital. And there's a whole rationale, there's a whole reasoning behind it. It's not just very absurd and random, And these are some things maybe we can discuss later in the group as well. So that is what we identified as a problem, that we need to get attention to women's health. We need to get men and women involved to take decisions for women's health, right? So, this is what we did. Now, on your left, you have a typical organogram of a health system, right? You have a state or a province. So, there's a health department there. Then there are several districts under that. Under that, you have several blocks. And the lowest unit of health administration is either a block or a village. So we wanted to work at that lowest unit, right? So what we did was we identified 3 districts. In each district, we identified certain blocks. And in each of these blocks, we identified some very hard-working, sort of very inspiring government health staff. And I say this because if you want to make change, you have to find the right people. You can have the money, you can have the great strategy, but if you don't find these charismatic, motivated people, it is going to take you a lot of time. So we found these very motivated government staff, health workers. They were either doctors or health education workers, and they were willing to put in a few more hours each week to be a part of this program that they didn't know about. That all they knew is that it's going to make their life better. It's going to get health services. It's going to improve uptake of health services. So, anyways, what we did was we identified that one government health worker, and then in each village we identified a local leader who we called a champion. So in Haryana, sports is a big thing. Haryana, actually, the state of Haryana produces all our gold medalists for the Olympics. I was going to say Oscars. We just get 3 or 4 medals, but all of those medals come from the state of Haryana. So we use the sports metaphor a lot because people really get excited when you tell them, oh, do you want to play a sport? Do you want to represent the country? So these local leaders were simple people from villages. They were teachers, sports coaches, barbers, tailors, grocery shop owners, could be anybody. As long as they had good communication skills, they had connections, they had social capital, and they were willing to spare some time. So we got a government health worker from the block, we got a champion who's a local volunteer leader from the village, we got them together, we trained them, we gave them certain kind of training in communication skills, a lot of audio-visual based training through mobile phones because we couldn't go there to every person just to reduce costs. And then we also got them in touch with the frontline health worker. If you remember the video that we saw, the lady Manju, so every village has a government frontline health worker. So we got them to work with this champion, and then we got local stakeholders involved. So if you can look at these images, if you look at the image on the right, the lady who's wearing a blue outfit, she may look like a very simple, subservient person there, but she is a very, very powerful woman in her village. She is a sarpanch. A sarpanch is essentially a locally elected leader. So a very powerful person in each village and very respected and influential. So, and this is a block health center where we try to speak to health workers. So we did a lot of community mobilization. We got local stakeholders to support this champion, and basically what the champion had to do was those 6 items. Very simple, straightforward items. They had to talk about anemia in their daily conversations with people in the village. They had to organize group meetings. Interpersonal referral is if you see a pregnant woman, if you think she's at risk for anemia, you give her the number, you give her support, you encourage her to go and visit the health center. We worked with teachers to conduct school events because we thought that talking to children would be very impactful because the children would then go and talk to their parents, and it really worked like that. We also actually went and spoke with vegetable vendors and kind of understood the sort of demand and supply issues of fresh green vegetables, iron-rich vegetables, and just to get a buy-in from them so that they brought more vegetables into the villages. Signature campaigns by students, and finally community events. So these are the very simple, basic things that can be done at the community level. And in each image you have that champion, you have that local sort of leader who's gone and spoken to people. And over a course of, I think, a year, we've actually recorded some very fantastic outcomes. And this is a project where, of course, there were costs involved because it's a pilot, and there were costs involved for hiring me, for hiring a couple of others who went in with the groundwork and who. But it's a good model for state governments that don't have too much of money, and for state governments to actually empower local communities and build that link with them. Because right now, what is missing is the trust in the public health system. And countries like India, where a lot of people rely on private health system because there is a lack of trust. So models like this can actually help to build trust, which in the long run can, improve that access and utilization of health services. So also an interesting outcome was number 4, increased sales of iron vessels. So that was one of the things we did. I mean, if you actually cook food in an iron vessel, you can increase the absorption of iron, which actually helps for people who suffer from anemia. It's a very simple hack, it's cheap, and the local iron vessel vendor was like super happy because he made a lot of money because of this project. And he's, I think, even setting up another shop in another neighboring village. So it's a total community model. Just to summarize, that improving maternal and child health, I mean, reducing the mortality is one thing, but then also ensuring that there is good health. You need to improve the health system. You cannot just rely on vaccinations alone. Of course, vaccinations brings down deaths drastically. But once the funding for vaccination is over and the health workers for that immunization campaign are gone, there is nobody else. So, or these health workers are burdened, overburdened. So, first and foremost, there needs to be increased budgets for health, which many countries that have very high maternal and child mortality, their health budgets are minuscule. Like I think India's health budget is 1.5% of its GDP, whereas it spends a massive amount on defense, for example. So strengthen national health system, train and support, especially support frontline health workers, especially instead of burdening them with taking care of all health issues. If we can give them a voice where decisions are made, because very often when national level decisions are made, frontline workers are completely missing. So, and they are the ones who actually deliver the health in the field. Promote intersectoral interventions. And when I say intersectoral, I mean it's not just the health department that can make a difference. It's education, it's water, it's sanitation. So many other different sectors can actually sort of mainstream maternal and child health in their work. And again, it's cost effective. And finally, the most important thing that I've seen in the work that I've done is, and I'm sure many of you will agree, you have to empower local communities. You have to make going to health facilities safe, a safe experience, and only then will mothers go, only then will families go to public health care facilities. Well, I have got this slide here, assuming I'd get a lot of public audience, but I think you guys are already involved in global health in some way or the other. But just, if this talk has taught you something new or has inspired you in any way or whatever, if you can get involved in some way, even as much as say reading about global health issues or signing up or identifying certain local organizations or seeing if there's any way, if you are interested, if you can get involved. Finally, I'd like to thank Professor Devi Sridhar, the Wellcome Trust, for the grant based on which we are doing this fantastic research and this exhibition, our program, the Global Health Governance Program, the University of Edinburgh, and of course, all the communities that have given me their time that I've worked with, and all the fantastic partner organizations that I've worked with in India. And here's my email address and my Twitter handle if you have any further questions or would like to keep in touch. Thank you very much.